most definitely you know where you are. Ultimate Health on Joy 99.7 FM. Back in the studio with Dr. Michael McCarthy, CEO of the Sinal Specialist Family Hospital, consultant obstetrician and gynecologist. We've been looking at uterine fibroids, causes, symptoms, and treatment. Started last week. If you just joined us, you're most welcome. Covered a lot of ground. I think we learned that they're benign. They're not cancerous. Growths within the uterus. We'll do a little recap and then try and focus today on treatment and management. Your questions and your concerns and experiences, welcome. WhatsApp 055 11 11 997. We're live on Facebook and YouTube. Ultimate Health on Joy 99.7 FM. Doc, good afternoon.
Good afternoon, Naughty. Good afternoon, listeners.
Yeah, great to have you. Charlie, today you're knocking a tie, Charlie.
Yes, I want to look good.
Oh, your mic. I beg, can we adjust Doc's mic a bit? Yeah, better?
Yeah, hello.
Yeah, sharp.
Can you hear?
Yeah. Charlie, this tie, way back, was it what we call paisley? Oh, Charlie.
I want to look good today.
You always look good, right? When I have you, then I have to think about what I'm going to wear and, but it balances, all right? You're welcome.
Thank you for the compliment.
Thanks for sharing your Sunday afternoon with me and my listeners. And we're going back to basis on fibroids.
Uterine fibroids, that's right.
Okay. We did our 101 last week, right? These are growths in the uterus, which only women have, right? And they come up because of various number of factors. Let me not call them reasons, factors, right? We talked about factors. A few symptoms and so on. Can we just recap 101? Just if you were asked, what are fibroids?
Yes. So as I said, a 20-second recap. Uterine fibroids occur in the uterus of the woman or the womb, as people would say, and they originate from the cells of the uterus.
Okay.
There are some people who are at higher risk, women of African descent, women as they grow older, women who have a family history or siblings or aunties or mothers who have uterine fibroids. There are some factors that could predispose one to increase fibroids, increasing in weight, the type of diet that one is eating, and so on. And they can give various symptoms. Most of them have to do with the menstrual cycle and with pregnancy-related issues like increased menstruation, irregular menstruation, painful menstruation, excessive menstruation, and so on. They may have some impact on fertility and so on. And they can the symptoms can actually be that severe as to impact the life of the woman, social life, sexual life, vocational life, and so on, make it very uncomfortable, cause severe anemia, and so on. But there is hope because there is treatment, there is thoughts about management and prevention, and that's what we're going to go in today.
Okie dokie. Now, these were growths. We established last week that they are not normal, though they are common. They are not normal, right?
Exactly.
They are common, right? And therefore, we should know about them. Women should know about them. We looked at the prevalence and we said, well, quite a high number of women in their reproductive life cycle will or may experience fibroids. But one of the things I want to bring back is you said that if they're not causing any problem, any symptoms of significance, you tend not to worry about them and you might tell the woman to leave them alone.
I think that's an important statement, and we want to refine that a bit and say that the management of the fibroid should be individualized to the person, because everybody has different circumstances and different things going on, and so we want to look at the woman and her environment, plus what is going on with these fibroids, and then tailor the treatment to that. And you are right, some people, in fact, most people will not have fibroids that are giving problems, and so could probably even just be left alone for a while.
Right. Okay.
Right.
Okay, so if you've been, told by a doctor nothing to worry about, and you're listening to Michael and I, we are not reinventing the wheel, but we'll speak to specifics. No woman is the same as another woman. No fibroid is the same.
That's right.
An assessment must be done. And Doc, can we hit on this? So all of these concerns and their determination or assessment, do they need to be done by a gynecologist?
Well, there are different levels.
Okay.
And the first level is the woman herself. She needs to understand what's going on with her and be able to give us what we call a history or a talk up of what is going on with her. So she needs to study herself, her cycle, how her bleeding is like, be able to give us how her pain is like, and so on. And that will give an idea. And also, how is it really affecting her?
Okay.
Some people may have more symptoms that are not really affecting them and others less. And so that's the first point. And the second point is the health workers. It does not have to be a gynecologist.
Okay.
At a point, a gynecologist will come in, but different things can be assessed by other health workers as well.
Okay.
Looking at the symptoms and maybe referring as the symptoms get more severe and require some more intensive intervention.
Okay.
And then they can be referred to the higher level.
Okay. So you know already that you're on the higher level because I've got the gynecologist here in the studio, right? But we're giving the general, universal overview, okay? Your specific concern or presentation will be unique to you. All right. And then there was some part about hormones, right? Stimulating the growth of fibroids, and the fact that as you transition from your reproductive phase, the likelihood of these, should I say, starting or continuing to grow decreases.
Yes. So there's the issue basically of hormones and time.
Okay.
So as these fibers usually start to manifest during the reproductive lifetime of the woman. So it's not likely to find them in someone who has not started her menstrual cycles yet.
Okay.
But they will start later on, 18, 19, 20, early 20s. And then they will start to peak as time goes on, 30, 35, because the fibers take time to grow.
Okay.
Some grow much faster than others, and there are some that are more slow growing. But generally, the exposure to the hormones goes with time. And so a number of years, and this growth is measured, let's say in years, let me say, not in weeks or months,
right,
but in years. And so it takes a number of years for these fibers to grow. And that is why the incidence is much higher in women who are like in mid-30s as compared to those who are in mid-20s.
Okay.
And then again, the hormones come into play when you are going through menopause and after menopause, because then the hormones are not many. The hormone level is not a lot. And so the fibers will then tend to stop growing, and they will also start reducing in size, maybe even up to 50%.
Okay.
Yes.
Right. That's where some of you say, well, I've been told they will shrink by themselves. And you need to understand what that really and practically or clinically means. Okay, so if you have any questions, we're on WhatsApp 055 11 11 997. We're live on Facebook and YouTube with Dr. Michael McCarthy of the Sinal Specialist Family Hospital. We're talking about fibroids. We've done a lot of the work already, but we're tidying up in the kitchen and then we'll start cooking again. All right, so we've understood that. We understood various placements or possible locations and types of fibroids. And these different types and these different locations had different clinical, should I say?
Pictures or impacts, yeah.
Right. Okay. So do we need to go over that or should we move forward?
I think we should move on because of time. But yes, that's very true.
Right. So once you've been diagnosed, a few other things will be done. And then there must be some discussion, planning and implementation of management and treatment.
Yes.
Okay. Can you walk us through?
Yes. So investigation is very important. So let's say a woman comes with excessive menstrual bleeding.
Okay.
We don't know what's going on. So one would have to take the history, as I said, and then the physical examination is very important.
Right.
Examining the entire person, to see what's going on. Is there anemia? Is there weight loss? How is the abdomen like? Is there a large mass in the abdomen? What's the size of the uterus? You know, and the history will talk about how much bleeding are you really having. And we usually do that by measuring, asking, so how often do you change your pad during menses? And that can give you an idea. And the average is about 2 to 3 changes a day and 1 change at night. So that means you're using about 2 to 4 pads during the day and maybe 1 to 2 at night.
Okay.
And if you are doing more than that, maybe you're losing too much. If you are changing every 1 to 2 hours, then that is really too much.
Right.
And the thing is that the increase occurs slowly, and so most people will not tell you they're uncomfortable, but when they tell you the number that they use, you realize that things are becoming in excess. And then we have investigations like an ultrasound scan, laboratory investigations to do blood tests and so on. The ultrasound scan is a very important one, which can actually look at the uterus and see where the fibroids are located, how big they are, how many they are, and so on, and differentiate this uterine fibroid issue from other things like adenomyosis or ovarian masses or ovarian cysts or other things that could be happening in the body. And so that will kind of give us a much clearer understanding of what is going on and help us to make a diagnosis that, yes, this is uterine fibroids. There are other things that can be done like MRI scans, CT scans, hysteroscopy or laparoscopy to go and see what is really going on. But the mainstay really is the history, physical examination, and the ultrasound scan.
Okie dokie. Right. So let's say we've gone through this investigative phase.
Yes.
Determining, isolating what really the picture is, what's going on. Is it a fibroid? Where is it? How big is it? And so on and so forth. What kind of disturbance is it causing, right? You've done all that. In the planning of management or treatment, many women talk typically only of surgery, which seems to be their dread. Right, that's what they're afraid of. But you educated us last week that there's a whole range of things that can be done before even a surgical intervention. So let's talk about those whole range of not necessarily that one comes before the other, but the focus or the dread is with surgical intervention. But what are the other things that you'll be thinking of doing? And then, of course, what are your considerations? Last week, you mentioned that you'd be interested in knowing whether the woman plans to have more children, where she's had children or not, and so on.
That's right.
What are the considerations?
Well, so before one can talk about the management of the woman, we need to understand what the goal of the woman is. She may just be interested in addressing the excessive bleeding or addressing the pain that may be coming, or she may be coming because she wants to get pregnant and she has been told she has fibroids and she's assuming that the uterine fibroids are the cause of the fertility issues. Or maybe she's had some miscarriages and it was noted that there were fibroids as well, and so she thinks that that's what I need to do. Or maybe someone has just told her that she has fibroids and she hasn't got any problems, but she's been told she has fibroids, and so something must be done. And so we need to understand where she's coming from, because the interventions would have to solve the problems that need to be addressed. You see. So that conversation has to be had and the investigation is done so that we can see where we stand. And then tailor the treatment to what will benefit the patient the most. For example, some people would come in and say, I want surgery for my fibroids. And then you go in and then you find that there's a 1 centimeter fibroid sitting somewhere on the outer aspect of the
minding
the
its own business.
Not even causing any symptom, but maybe she did an ultrasound scan for maybe a health screen or something. And found that, and she's worried. And so if one would want to do surgery for that, that would probably be an overkill. And maybe more disadvantageous than advantageous. And so you'd want to say, well, this may not require surgery. Let's use another method. Let's just monitor this fibroid every year. and see, is it growing? Is it giving you symptoms? Is it giving you problems? Things like that. Or she's coming for fertility issues, and the fibroids may not really be the cause, maybe much smaller, less in number, location not affecting fertility. It could be wise at that point still to wait rather than to go in for a definitive treatment.
Okie dokie. You're hearing this from Dr. Michael McCarthy. I'm seeing somebody in Dansoman saying, can I get his number? I'm sure we can share the number for Sinal Specialist Family Hospital in Tema. I'm the only one who has his number. Don't go there. All right, but no, it's not that difficult to identify. He's at Sinal Specialist Hospital, Community 6, Tema, right? Please, can I get his number? That's from Ejapoma in Dansoman. We'll see what we can do about that. This one says, hi, Naughty. Ask the doctor. I saw my last flow in May whilst I was away on a business trip. I've been back since, but I can't see my flow since the last one, and yet I get all the symptoms prior to that. PT is -2. All right, we are swaying again towards menstrual cycle. Doc and I know this familiar trend. Not a good afternoon. There's a lot of misconception about this fibroid thing. My problem is the herbal doctors and centers who claim to be treating fibroid. As a sonographer, I find it very difficult to work with these herbal centers because they expect you to do things you don't want to do. How is the system working in Ghana to stop all these issues? Senyo in Adenta. So, sonographer, he's into the imaging, ultrasound, and all that, I guess. Yeah?
Yes, a sonographer does ultrasound scans, and is one of the people who are capable of diagnosing fibroids via ultrasound scan, identifying them on scan. It would be interesting to know what he means by
things that he doesn't want to do.
Things the centers expect them to do that they don't want to do. It would be nice for him to send us a message on that. Yeah.
Is there anything in terms of the professional medical fraternity addressing some of these, what he calls misconceptions? It means they're telling people wrong things about fibroids and so on and so forth. And they're sending the people for imaging, and then there's some dialogue which is confusing. That's what anyway, Senyo, send us a follow-up so that we can address your issue properly. The other one says the lady who last saw her flow in May on a business trip, she's back, and she says PT is -2.
I mean, from May to August is about 3 months. So that requires some investigation to find out why the period is not back. So she definitely needs some more investigations to see what is really happening with her. Yeah.
Further and better particulars we need from you, Ekuba. Right? Hi, Note. Does having rheumatoid arthritis make you prone to having fibroids? I've had one myomectomy 5 years ago already, and the fibroids are back. From Ajo. Last week we talked about the possible recurrence of fibroids after an intervention.
Yeah. And 5 years is the average time within which they would come back. They'll grow back. Yes. So I'm not surprised that 5 years on, she has fibroids again, because new fibroids keep growing. Whether you remove the fibroids or not, new ones keep growing. So even if you don't remove them, you just have many more growing at a time. And so appropriate treatment must be done. And that's why the goal of treatment should be looked at very carefully, because we know they will come back. Not that they come back, but new ones would grow. And that could then cause a new problem.
Right. So the woman needs to be helped to understand this.
Yes.
Right. And also, I heard you say quite distinctly that you listen to her and her viewpoint, her perceptions, and what she's looking
to achieve. Yes.
Right. Why she's presenting, what she's looking for, and then that is taken into consideration in the planning of the intervention.
Yes. So, for example, we know that the new ones will grow, but it's not for everyone. I've had quite a number of patients. You remove the fibroids and they don't get any new fibroids over time. But we digress. Assuming you treat a woman, she's coming with uterine fibroids, she has fertility challenges, and she desires to get pregnant. And you remove those fibroids. The next point is that we must achieve a pregnancy.
Okay.
So we don't want to wait for 5 years and then say, okay, we've been trying for 5 years, it's not come. No, you need to go up the fertility ladder very quickly.
Right.
Natural means, medication, intrauterine insemination, IVF, and other things very quickly rather than very slowly.
Okay.
And I think sometimes the couples miss this. And so they assume, okay, we've moved our fibroids, so we've solved the fertility problem. But there may be other issues that are going on with the fertility issue. And if you don't solve them at the same time, you wait for a few years and new fibroids start growing and you're back to the first problem in a worse way.
Wow.
So that's why that management plan is very important.
Okay.
So if we are doing it for fertility, then we are also helping to make sure that pregnancy is achieved within that shorter time rather than longer time.
Okay, great stuff. 28 minutes past the hour of 2 on Joy 99.7 FM. The program, as always on a Sunday afternoon, is Ultimate Health, your ultimate guide to healthy living. With me, Norte by Nature, we're speaking to Dr. Michael McCarthy. The way he explains it, already you should be talking to the right person. Because yes, this is the plan, this is where we are going. We've done level 100 of the plan, and then you disengage with your doctor, and then you think everything else will follow in that plan. He's saying no, there must be conscious, deliberate management of the steps to attain the goal of the plan. If it is to get pregnant, certain things need to be going on and need to be monitored and managed, okay? Apart from the fibroid being managed or removed or whatever. So bear that in mind. We're live on Facebook and YouTube. WhatsApp is 055 11 11 997. It's about 5:30. So I will activate phone line 030-221-6541. You can ask the questions yourself. I know there's always this temptation, this whole tsunami, which threatens to move us into menstrual cycle, but we'll try and stick on the management of fibroids. Okay, so yeah, we've talked about, or we've read most of we don't have any. Oh, we have new ones. Okay, this one says, thanks, Norte. No, we didn't connect the rheumatoid arthritis and vulnerability to fibroids from Ajo.
Yes, Ajo also asked that. I don't know of any link between rheumatoid arthritis and uterine fibroids.
Okay.
No.
All right. If doctor doesn't know me, I don't know. All right. But you can send your 055 11 11 997. Good afternoon, Norte. How are you and Dr. Michael? We're fine. I can answer for him. He always looks fine. Please, last week, doctor told us that when the person is of a younger age, fibroids grow big, but when they enter menopause, then the fibroid reduces or shrinks. My question now is that why does the fibroid shrink during menopause rather than instead of the age of the woman, right? From Hayford in Bato. So we explained the, decline in the prominence and activity of the hormones. But Doc, Hayford wants to know, he says you said something suggesting that when you're younger and probably in that reproductive phase where the hormones are doing their business, then there's activity of the fibroids, but then this slows down when you're postmenopausal.
Yes, so I think he is expecting that the fibroids should be growing as age also increases.
Right. Uh-huh.
But then the factor here is that the fibroids will only increase if there are significant quantities of the hormones, estrogen, progesterone, right, which we know reduce during menopause. Mm-hmm. So Hayford, after the fertility time is passed and after menopause, those hormones reduce, and so the fibroids will also reduce in size.
Right. Oye Inafienya, today you are late. It means you are eating something without inviting us, but you're most welcome to Ultimate Health. This one says, okay, that's from Ajo. She says, thank you. You're most welcome. Right. Any more questions? 055 11 11 997. Live on Facebook and YouTube. The phone line is active 030-221-6541. We're talking about fibroids. Okay, so we've gotten a certain understanding. It's not as if the doctor is trigger happy and wants to go snipping and clipping and chopping, but he considers a whole range of things. Okay, so Doc, what else do we need to know in this? I like something you said. As soon as you do this, if you have fertility and conception in mind, you must climb up the ladder with regards to fertility and the possible options for assisted reproductive techniques, and also the other things, in a whole range. So you don't just sit there and say, okay, it's been done, now Jesus take the wheel, right? Jesus has asked Michael McCarthy and people like him with the requisite professional qualification to look at a range of options, right? And I think that's a significant point you made there. Don't just wait. These things have a tendency to spring new growths. So if you wait, then we say, oh, there's another thing, and so on and so forth. We should be busy.
Yes, exactly. I mean, the range of options are there. Yes, of course, yes, the couple should continue to be busy.
Okay.
But then we need to understand that there are different levels,
right,
and we need to do them.
Okay.
We need to go through that ladder.
Okay.
Yeah.
You mentioned that we may be giving you medications for a particular symptom and so on and so forth. We may be doing a whole range of things, none of which are surgical in nature.
Yes.
But will be effective in managing the movement or the progress towards the attainment of the goal set for the particular women.
Yes.
So I've set some goals with you clinically, and I do not need to depend on surgical interventions for some of them.
Yes.
Okay.
Yes. So let's take for example, the woman is having excessive menstrual bleeding, and that is causing anemia. We could use medications to reduce the flow of blood during the menses, and also to build up her blood level. She may not be interested in pregnancy at that time.
Okay.
And maybe a plan for pregnancy is 5 years from now.
Right.
So instead of removing them now and then having them new ones grow within that 5-year period, you can delay the time when surgical intervention may be necessary, and push it closer to the time when she plans to have her children. And so you can then just manage the bleeding using medications or hormonally active IUD or things like that. Okay.
Right. This one is from Zet in Akweteman. Great topic as always, and Zet chooses to call me Bote by nature. I receive it. Kindly ask doctor if I should worry about my concern. So after the birth of my second child about 7 years ago, I was told I had a little fibroid, but I should not worry because after that birth is really insignificant. So, I went back again to check, and I was told it was growing because of my pregnancy. I really don't feel anything with some of the symptoms doctor mentioned. I flow normally, even with the IUD I have in me. Thanks so much. But you are invited to my, is it fufu with chicken light soup? Okay, all right. Any comments on that, Doc?
Yes, I think this is great. So obviously she's managing this according to her need, and according to what is going on with her. She even has an IUD in place. Which she needs, and so for her, it's a 1 year follow up to see what's going on. Is the IUD being pushed aside by the fibroid, or is it still fine? Is the fibroid growing, giving her symptoms? And so just a year's review is all that she needs at this point.
All righty.
Yeah. So nice example. Yeah.
Right. Doc and I will come for the fufu with chicken light soup. People, I thought we were all on a haircut. It's happening for some people. Okay, I have fibroids and was placed on Zoladex 10.8, so not menstruating currently. Are there any side effects if you're not menstruating for 4 months? I'm 45, no pregnancy needed. This is Ajo Mansa.
Right. So again, you see the need of the woman is clear, and the doctor here, excellent work done. He has looked at what is going on. He's given her medication which just addresses the size and the symptoms temporarily. She's at 45. She may be going towards menopause, so he's hoping that he'll be able to solve the problems temporarily, and she'll get to a point where she does not need the medication anymore. She also does not need pregnancy at this point, and so it's being managed in this very simple way. And but her question was, is there a problem if I don't have my menses for 4 months? In this case, she's on a medication which will postpone her menses for 3, 4, 5, 6 months probably.
Okay.
So it's to be expected that if she's on this medication at this dosage, this should be normal for her as a side effect of the medication.
Okay, I love the fertility and the conception on our WhatsApp line. Lots of questions that are giving birth to other issues. That's why we're here this and every Sunday, 2:05. If you have a question or concern, 055 11 11 997. That's where all the fertilization is going on. If you want to do it directly, then the phone line is 030 221 6541. Ultimate Health on Joy 99.7 FM. My partner in studio, not in crime, is Dr. Michael McCarthy. He's the CEO and consultant obstetrician gynecologist at the Sinal Specialist Family Hospital, right? And they do much more than fibroids. But he's our guest today, your guest today. So send your questions or hit the buttons and make a call and ask him. Oh, don't worry, Zet. She said typo. She made me bote by nature. I know some people start using it. That's how they are. They'll forget everything we discussed, but they'll remember that. All right. So coming back to the business. So we've got this range of things, and like, was it Adjua's example? The intervention is tuned to my needs, my requirements. So she's been put on medication, and she's fine. Yeah. But more importantly, her doctor is also monitoring what's going on with the fibroid.
Exactly.
Okay.
Exactly.
He hasn't forgotten. He knows your history. He knows your plan.
That's right.
And he's monitoring. Okay. So stick and stay with him, your doctor and your provider. What's next, Doc? We haven't really gotten...
Right. So we've demonstrated maybe the first line of the management, which is just wait. Second line is put on medications either to reduce symptoms, reduce size, address pain, address bleeding.
Okay.
Then the next level of treatments are surgical interventions, of which there are different forms of surgical intervention. So the major, bigger forms of surgical intervention are either myomectomy or removing only the fibroids, or a hysterectomy, removing the entire uterus or womb. And each of these have different ways they are done. Some are open surgeries, which have an incision in the abdomen like a cesarean section type of scar. We use that because a lot of people know how that looks like.
Yeah.
Or it could be by laparoscopy, where little cuts are done and instruments are used. Or if the mass is coming out through the vagina, the myomectomy can be done in that way, through that route as well, without having to have a cut anywhere in the abdomen.
Okay. Doc, before we go further on this, with your permission, I haven't heard you directly speak of, or mention any intervention before we get to surgical that is designed or claims to be shrinking the fibroid. We hear a lot of that, okay? I'm not going to take it out. I will shrink it, right? And we hear a lot of claims, okay, sometimes by people without your requisite qualifications. Is there any line of intervention where the client may be told that an intervention is designed, or a medication is designed to shrink the fibroid and therefore address the problems it's causing?
All right, so generally, there are no medications that will permanently shrink these fibroids.
Okay.
We know that sometimes during pregnancy they undergo degeneration, or so by the time you check on the fibroids, after the pregnancy, you will realize that these fibroids are no more active and they are no more growing. So that's one group.
Okay.
But we don't have medications that will actually shrink these fibroids on a permanent basis. We do have some medications that will temporarily shrink the fibroids, like the woman who said she didn't have a period,
right?
Because she was on a certain medication. That's exactly what that medication does. It will shrink everything down to a much smaller size. And we use those medications getting to menopause, or for people who are preparing for surgery. Maybe the mass is quite large,
Okay.
And so you would not want to have a very large incision at surgery. And so you give those medications to shrink the mass.
Okay.
And then you can use a smaller incision or cut to do that surgery.
Okay.
Or they are bleeding a lot and you cannot get their blood level to go up without a blood transfusion.
Okay.
And so you'd want to give those medications to reduce the symptom of bleeding and size.
Okay.
And then you can build up the blood level to a good level, safe level for the surgery. And then you go ahead with the surgery, because as soon as you stop the medications,
right,
and you can't give them for very long, just a few months.
So it's really a suppression.
It's a suppression kind of that shrinks the fibers,
Okay.
but in a suppressive way.
Okay.
For a shorter period
I
of
won't
time.
give you what you need to grow.
Exactly.
And therefore...
And so then you can then go ahead with your surgery, and then you've removed the fibers, and so you don't need to give that medication again. There are some tablets, not in Ghana yet, but licensed in Europe, which can be taken orally, but also for a limited period of time, which can reduce symptoms of bleeding and pain and so on, because they help to shrink the fibers. But again, temporarily, and these medications do not improve your fertility, because the fibers are still there, and whilst you are taking them, they will also not allow you to get pregnant. And so that becomes a solution, an interim solution,
right. It's part of
whilst you are looking for that permanent solution. Yes.
Okay, I hope that is understood. And because again, I can't speak for herbalists, right? But we hear of many people drinking something, saying it comes from here or there, and it is alternative this or something pathy, and therefore I don't need a surgical intervention, and I'm on this thing. I go every couple of weeks to take this thing or concoction, and it's supposedly shrinking my fibroids.
I have a few patients who have come over with, saying that we've taken this medication and so on. However, I have not had anyone proven that the fibroids are actually becoming smaller. When I measure them before and when I measure them when they come back, you don't get that reduction in size that one is looking for.
Right.
So I'm also looking for that medicine. When you find it, you should let me know, because I think that will be a great solution.
Right.
Because if you can have a solution without surgery, I think that's a good thing. If it can solve the problem and help us to achieve our goal. But so far, I have not been shown any proper proof that we can actually shrink these fibroids using these medications, as some people say. But we are always open to new things and better solutions. So if they are there, we would like to know, but we have not seen them yet.
All right. We are of the scientific model. So if it is scientifically efficient in doing something, it must be replicable. And it must be replicable across cases. And Doc says he's not aware of any such proven medication or concoction. This is from Dede in Maryland. She says, I thought fibroids thrive on blood supply. As such, during menopause, the fibroid shrinks due to lack of blood supply. But I heard Doc saying hormones rather. Some of the interventions are cutting off blood supply. Right. She's putting forward what she knows or has heard, and putting that against what we mentioned, the activity of the hormones. Any comment?
Well, yes. That's a critical thinker. She is thinking. She's putting the facts together to see what's going on. And so the hormones will work to reduce the blood supply as well. And so you realize that the blood supply to the uterus is much less during menopause than earlier on. And so, yes, so there is that whole progression. The hormones are increasing the blood supply and so on. So you could say blood supply, you could say hormones, but they are all part of the things that are working in the process. Yes.
All right. Thanks for sharing that, Dede. 46 minutes past the hour of 2. We want to quickly get back to the surgical intervention and understand them. And an HSG indicated a bilateral blockage. A scan showed a fibroid. Now, this person lists them in point order. Is the fibroid the cause of the blockage? 2, can I ever have children? I'm now 45 years old. If the fibroid shrinks after 45, is it necessary for me to have them removed And are these herbal remedies useful? We've given our take on those ones. Ajua and Kofrida sends this.
Right. This is really academic question number 1 to number 4.
Number 1 to 4.
And HSG, that is a hysterosalpingogram. It's a test where a dye is passed through the uterus and then an X-ray is done. And so you see on the X-ray what the shape of the uterus is, what the shape of the internal cavity is, and whether the dye is passing through the fallopian tubes. And according to her, it showed that there was blockage of her tubes.
Right.
And so it could be that her tubes are not working.
Okay.
And that is why it appeared in this manner. And she says an ultrasound scan also showed a uterine fibroid. Actually, the HSG can show some defects in the cavity if there are fibroids in there.
Okay.
A little technical, but maybe we shouldn't go into that. But she's asking, can the fibroids be the cause of the blockage? Usually, the fibroids do not block the fallopian tubes.
Okay.
They are more smooth, and they can distend the fallopian tube. They can pull it in a particular direction or push it aside, but they generally do not block the fallopian tubes themselves. And so that is not likely to be the cause of the blockage in her case.
Okay.
She says, can I ever have children? I'm 45. We know that pregnancy rates after 40 are much lower than before, and definitely after 45, it's not very common to find somebody getting naturally pregnant after 45, though possible.
You may need some assistance.
But then with assistance, we're now having a lot of women who are 40 years plus who are getting pregnant through assisted reproduction, IVF, and so on. And so that could be a possibility. If fibroids shrink after 45, is it necessary to have them removed? It depends. So if she now wants to have an IVF procedure and she has large fibroids, and even though they are shrinking and they are significant, she'll still have to have them removed if she wants an IVF procedure. However, maybe she doesn't want to have that, and if there are no more giving symptoms, then there is no need to remove them.
Okay.
Yeah.
All right, great stuff. Ajwa in Kofrida.
And then the herbal question. So are these herbal remedies useful? I don't know which ones she's referring to, but I have not found any herbal medicines that are actually reducing the size of uterine fibroids or melting or shrinking them so far in my practice. And for now, I've not found them useful.
Okay, great stuff. 49 minutes past your hour of 2 on Joy 99.7 FM. Ultimate Health, your ultimate guide to healthy living. We're speaking to Dr. Michael McCarthy about fibroids. Good afternoon, Norty and Dr. McCarthy. I'd like to know how soon after a myomectomy one can start with assisted reproductive treatment in line with fertility and conception. So the goal is there. I've had a myomectomy or a removal. Do I have to wait for a while?
After 3 months, yeah.
After 3 months is the answer?
Yes.
Okay.
3 months.
Why after 3 months?
Well, so we use that as an arbitrary cutoff to say that, so after this type of surgery, you wait for 3 months before you start trying to get pregnant. And you know that getting pregnant is usually a process, and in the IVF line also. And so that takes some time because you want the uterus to heal and all these scars to form very well so the uterus will be strong enough to carry a pregnancy.
All right, 3 months and beyond, you should be.
Yes.
All right. Good afternoon, Joy FM. Please, the people of Darwenya have been sleeping without light for the past 2 days. We cannot top up our meters. Please tell ECG to wake up. ECG, wake up. Right? Done. Right. Okay. Thanks for sending that. I guess that's also serious business we need to talk about. Okay, great stuff. So let's quickly come back to the business, about surgeries. No, please get to the bottom of this act. Okay, that's not for us. Maybe sometimes some of Samson's legal questions filter through here, straight through here. Right, so Doc, we mentioned you can have an open surgery to remove. You can have some of these small incisions with all the fancy gizmos that you guys have, right? That is surgical intervention. That is surgical removal of the fibroid.
Yes.
Okay.
Yes.
So can we just talk quickly about the two?
Yes, so I think that we need to understand the two, that there is the myomectomy type or group, let me say, and then there is a hysterectomy where we are removing the entire womb. So it depends on what the woman has as her goal. If she does not need the womb anymore, because maybe she's completed her family or for whatever reason, then the most definitive treatment of uterine fibroids is to remove the womb, because that is where the fibroids come from.
Right.
And so once you remove that, there's not going to be any recurrence. They are not going to grow again, and so on. And so complete removal of the womb.
Right.
For those who still want to retain their uterus for reasons of pregnancy or other reasons, we will then do myomectomy, which is removing the fibers out of the womb, so to speak.
Right.
Taking them out of the womb. And repairing the uterus, putting it back together so that it can then have its normal function, as close to normal as possible.
Right.
And each of these procedures can be done in various ways. They could be open surgery, they could be laparoscopic surgery, they could be vaginal surgery. Most people don't know about vaginal surgery. Maybe we'll talk a little bit about that, because that is a very interesting way of doing surgery, where the entire uterus is removed through the vagina. And so there is no cut in the abdomen. And so at the end of the day, you don't actually have a scar on the outside. It's a scar on the inside. And recovery is much quicker and so on. And maybe that's the true non-invasive way of doing surgery.
Right.
In a
so
way.
there are different ways of removing the fibroids,
depending on where they are located, what we want to achieve, what would be the best way to address it, and so on. There is also a less invasive method called hysteroscopy, where we go through the uterine cervix and remove fibers that are in the cavity of the uterus only. And this also does not involve any cut on the body, and so it's much easier to address. Can be used for smaller fibers that are very close to the inside part of the uterus. It can also help in enhancing fertility.
Right. We're commencing descent. We want to touch down. But Doc, removal of the uterus, hysterectomy. Right? There's partial and there's, is it total? Right? With or without the ovaries, or can you just touch on that?
So removal of the uterus can be done removing the uterus without ovaries, or you could also remove the ovaries at the same time. It depends on the age of the person. If the person is older, you would want to remove the ovaries as well. If the woman is younger, less than 45, 50, you'd want to keep the ovaries, because the ovaries still have some function. They still release some hormones, make your skin, your hair fresh, and sexual activity and so on. And so you'd want to leave the ovaries. But when you're older, past 50, then we would consider removing the ovaries as well, because of risk of diseases of the ovary, like ovarian cancer and cysts and so on. And so that will be the deciding factor. There's the other part of total or subtotal, as we would call it, where we could remove the entire uterus, that is uterus, the cervix, and every part, maybe more technical, or part of the uterus where the cervix is left behind, and they have the different advantages, disadvantages, technical reasons, and so on.
I'm looking at you. So for the woman who has a hysterectomy, right, or a total hysterectomy, it's addressing a specific clinical presentation or problem, but afterwards, post the intervention or post surgery, is she still? Women ask me as a psychologist, am I still a woman? Will I still feel like a woman? And so on and so forth. They have some misconceptions. So what is my status after a hysterectomy?
You're still a woman.
What is missing?
You're still a woman. I mean, not will you say that if somebody has lost an arm, he ceases to be a person? You're still a person, but maybe a part of the body is gone. Or you had an issue, you had an ectopic pregnancy, and one fallopian tube was removed. Well, you're still the person, though some part has been taken out. Or if you've had a problem where you had to remove your kidney, one kidney was taken out, you're still the person. You're still that same person, actually.
No monthly.
If you're called Michael, you're still called Michael.
No monthly cycle.
But then certain things will change, depending on what part of your body was removed. In this case, it's a uterus, and it's more. It has to do with fertility, so it looks more sensitive in terms of psychologically, and so people think that, what's going on with me? But partially, it also has to do with the hormones. So, and that's why we have to be careful when we are removing the ovaries and when we are not removing the ovaries, because it's the ovaries that give the hormones. And that's why we are saying that when they're younger, we leave the ovaries behind. And so you don't have so many of the challenges of menopause happening at the younger age. But if somebody has already gone through menopause, then removing the ovaries will not cause so much change in her psychology and how she feels and how she thinks. But this brings us to the fact that if one is undergoing a hysterectomy, some counseling too is needed. Why are you doing the hysterectomy? Do I even agree that hysterectomy should be done? How does one think about it? And so the pre-op counseling is quite important, and even post-op counseling quite important. But you definitely are still a woman. Yes.
All right. This comes from the lady who gave us the HSG point by point, the bilateral blockage, right? She says, great response, thank you. But is the waist pain that I experience after my periods a result of the fibroid?
Not likely. There's so many causes of waist pain, and I don't think the causes of fibroid is the main cause of waist pain. I think that there are probably many causes: poor posture, excessive weight, problems with the spine, muscle spasms, and so on are probably more current problems that are causing waist pain rather than uterine fibroids. Yes, if you have a very large fibroid, or you have a fibroid that is maybe located through close to the spine or something, yes, then you may have some pain, but that's not the major feature of uterine fibroids. I find that we tend to blame all our symptoms on uterine fibroids rather than trying to look for what the real cause is, you know. And so it's not surprising. But this is not most likely not the cause of her back pain, and we should find a reason for her back pain.
All right, great stuff. Any remedies or solutions aside surgery, please, for the same woman?
For the back pain is not usually addressed with surgery. Back pain, you won't find out what it is. It could be massage, it could be change of posture, it could be other spinal interventions, and I think a proper diagnosis should be made. Someone here is asking, what is CoCo? We did that with Doctor, why have I forgotten his name now? But piles, right? So that's what CoCo is. We did that a couple of weeks back or months back. If you check our podcast and stuff, it should be available there. So Doc, we've gone through the whole range, and you suggest to us that this is done in consultation with the woman, so all her fears, anxieties will be addressed or should be addressed before any intervention. From the way you speak, definitely you're giving a lot of information, you're explaining to the woman